Welcome back, everybody, for a new episode. Today we have female hormones on the docket.
You may be wondering why we're talking about it as two guys, but it's one of those things where I personally, my wife had issues with this, and we had to, seek out a functional provider to kind of help her dial it in. And I think it's one of those things where when we hear histories and take in new patients in our team, it's a very common thing that impacts a lot of women is issues related to their cycle. So
Sure.
we want to be very kind of dialed in terms of what's normal, what's not, what's abnormal, kind of what's the purpose of the hormones to begin with, and just kind of make this a very informative to a functional conversation. So.
Yeah. What's typical with healthcare? What we should be looking at to maybe change when we're doing things, and when people are looking to do things a little bit more naturally, what they could be looking at doing as well. So having, not just using traditional therapies, but using nutrition and supplementation and detoxification and things to look for that mess with your hormones as well, like from an environmental perspective, and wanting to dive deep into that today.
Absolutely. So, Dr. Nutt, you are hearing the word female hormones. Which hormones come to mind?
Definitely estrogen. I think that's the thing that most women would think of. Progesterone for sure as well. I think everyone kind of puts their, estrogen and, when it comes to getting pregnant or having normal cycle or birth controls and stuff like that, everyone kind of immediately goes, women use estrogen, men use testosterone. And
we all
have both.
Exactly. I mean, estrogen, kind of some of the benefits of estrogen, it's a growth hormone. So it's going to have really positive effects on, bone metabolism, cognitive function. But when kind of female cycle, it's going to be the hormone that builds up our endometrial layer, right? So that layer that's shed every month. So important when we have this conversation, especially when we start to discuss abnormal.
What's the purpose of that layer, Dr. Rayner?
It needs to be fertile. You need to have a nourishing place to implant if there's a viable pregnancy, right?
A nice mattress for the baby to lay on.
Right, and so the other secondary kind of hormone is progesterone. And so that's more of the start, the second half, post-ovulation, but it's kind of there to protect that endometrial layer, as well as help signal some changes of secretion to kind of make sure there's good adherence of fertile embryo if that's or fertile event if that's occurring. So when we picture, and this is something that our team likes to draw out, because again, I think it's important to understand what's normal. So when things deviate away from normal, we are going through in a thought process of like what might be the culprit. And so if you picture, the day you start your cycle, day 0 of a cycle,
which is day 1 of
a new cycle,
but day 1 of bleeding,
correct.
Yeah, a lot of people kind of think like the bleeding phase is the end of the cycle. We want to kind of put it out there. Day 1 of bleeding is day 0 of a new day cycle. 1 of cycle. Yeah.
So if
the start of a cycle.
So if you picture estrogen is going to be low but start to rise, and it's going to have this nice arc. So FSH hormone is going to be a big push for estrogen, and you're going to see that kind of peak into ovulation, have a bit of a dip, and there's going to be a small dip again, and it's going to decrease towards the end of your cycle, whether it's be day 28, 24, 31. Again, that's what estrogen likes to do. Progesterone is going to be very kind of not really making much noise. So initially from day 0 to ovulation, it's going to be, if you look at LabCorp ranges, I believe it's 0.1 to 1. It's going to be really, really low until you have your luteinizing hormone pulse off the pituitary. That's going to then push progesterone up. And then it's going to, again, decline if there's not a fertile event. And so those are really important. So I always ask, and our team asks and draws this out. It's like, where would be the most important time to test your hormones? Do you test, especially if you want to make a good insight on progesterone and how you're responding? Would you test it, where it's 0.1 to 1, or where you should see it peak and respond?
I think a lot of the times you want to have testing done when you are supposed to be producing those hormones, right?
Correct.
So like, you don't want to test right before a period starts, because what's happening to both estrogen and progesterone.
But it happens all the time where
Oh yeah, and then off of one blood test,
it's normal. You're fine.
or it's low, you need replacement, right? It's like you're just low, you need this replacement, and knowing when to do the testing is super important. So I think having testing done, like if we're looking at fertility, right?
Mm-hmm.
Maybe we should be looking at it right before that ovulation happens to make sure that, number one, like you're doing some ovulation management, if you will, about like knowing if you actually are ovulating.
Well, and I think that's another common question our staff and our team asks, like, do you know when you ovulate? And a lot of times like, oh yeah, I have an app that tells me that. I'm like, so, but do you feel it? Do you know what that feels like? Do
you know what
do you know for sure? You see it's like
what the signs are? Yeah,
the signs, like, so you may see more secretions. You will see so we didn't talk about testosterone. So ideally you'll see testosterone have a small pulse or increase during ovulation, which again, pretty intelligent design when you start to step back, because that's going to help increase libido when you are fertile. So you may see better workouts, better focus during that time, more libido, the secretions that I talked about. Those are increase in, you might feel warmer. Those are other things. I mean, again, why guess? I mean, a lot of times we'll make the recommendation if people don't know that phase, and we want to test and make sure we get good and intelligent and meaningful information, we want to be for sure that, hey, yeah, you actually ovulated. Because again, it's not always mid-cycle. Some people may ovulate like closer to day 10, some might ovulate closer later in their cycle. And so
not uncommon for it to be happening early as well, kind of peaking a little bit too soon.
So if we're trying to gather that information and make intelligent insight about what's going on behind, maybe if they're infertile or if they're not having trouble conceiving, or some of the kind of symptoms that they may be having that are abnormal, again, it's really important to acquire that information at a time that is dependable in terms of what should be happening. So you can go online and get LH urinary strips for pretty, $20 at the most, and that's like probably 100 pack. And again, it's just a urine test looking to see an increase that would match that luteinizing hormone or LH pulse that would then push that kind of be the signal of the ovulation phase. And so what, normally if we see that, we then ask our patients to then do what? Wait how many days? Usually about 4 to 6 days to come in to allow progesterone to have its rise and peak before we actually draw and take a sample. Now, that's kind of the normal kind of flow in terms of like cycle.
Well, after ovulation, after we get this nice peak in estrogen, a little bit of testosterone, progesterone starts to kick in. Usually that's where we're seeing people like, this is my best. This is when I'm feeling, women are going to be saying, I'm feeling really good at this time, right? And then, I mean, I'm speaking for myself, but clinically,
you're a woman?
I think clinically speaking, patients are generally, and women are generally going to tell me that the second half of their cycle, in general, is probably the time where a lot of their symptoms are going to increase. Their anxiety, the sleep problems, the gut problems.
We'll get into some of that.
Yeah, some of the inflammatory stuff. So with the second half of the cycle, we talked about the peaking of basically that LH surge and what's happening with your estrogen, testosterone, progesterone, and then what happens in the second half of the cycle.
So kind of going through that, because again, I like our team to be very educational when we have these conversations, because I think it's really important. One, symptoms are less scary if you understand why they're there, and it's also kind of gets them like, oh, there's a reason for why I'm having really, really heavy cycle. There's a reason why I'm having a period for a week that's incredibly heavy and goes on for 2 weeks, but like 5 days of very heavy. Let's say if you have if estrogen is a growth hormone and you have an abundance of it or more than relative norm, you're going to potentially see a thicker endometrium developed. So it would make sense that you're going to have more to shed and menstruate. What feeds that layer?
Estrogen. Blood flow.
Spiral arteries, these massive corkscrew arteries that go to that layer. So when and this is the other thing I try to my cramps are so bad. So to kind of starve that tissue to initiate the sloughing off, to initiate kind of the cycle, you also have to have smooth muscles constrict to retract those arteries away from that endometrium. And again, high inflammation increases our pain fibers, so you might have a higher perception of cramping or pain or discomfort. But again, if they have to go more and further to a thicker layer, there's also this thought process of you're going to have more smooth muscle constriction to push those arteries and retract them so you can initiate the process.
And more inflammation because you got bigger, thicker arteries climbing into there.
Exactly. And I think that's, when you start kind of just, women they appreciate kind of having some insight. And again, I always joke, I'm like, I wish it wasn't me having to, or our team having to explain this to you. Like, you know, you let's say somebody's 35 or 45 years old in our office, but they've had, you know, menstrual like symptoms since they were 14. I was like, man, it's a shame that this has not been kind of discussed and kind of educated to you in a way where you at least can kind of be more empowered by understanding like why these things are happening. So again, it happens all the time, and it's always just like, if we had $1 for every time our team has to go through and just touch on these very basic principles of hormones.
Because the traditional care is, I mean, it's the same thing almost every single time.
Yeah. So, you know, and so again, let's say, you know, that's kind of what should happen. So it's easy, then we can start extrapolating when things don't happen or start to deviate away from it. So what would you say what are diagnoses or things that they might be diagnosed with that would show an abnormalcy of female hormones?
Probably the most common one that we hear is like PCOS, polycystic ovarian syndrome, which when you think about it is like, okay, we have a signal from our brain saying, let's do this. Like, hey, ovaries, let's do this. Let's make more of these chemicals. And if you have an overabundance or an inability to get rid of some of the hormone that makes those ovaries do stuff, you're probably going to see some polycystic ovarian syndrome, plus add a little bit of insulin problems or blood sugar issues or other inflammatory issues. And cystic formation can be, you know, pretty common. Same with the uterine, same with breast.
Right. So endometriosis is common when there's abnormal cystic acne. I would say is probably a common one. Cystic breast formation. So you get really sore engorgement of the breast tissue. Abnormal cycles, so shortened cycle, heavy cycles. I mean, obviously the worst case scenario, your estrogen-based cancers and their role. And then mental health. That's actually probably the most, I don't know, I say reported, but it's just
the anxiety aspect of it. It seems to be almost everybody that we see in our office tends to have problems in the second half of the cycle with estrogen detoxification, and the symptoms of having excess estrogen tend to be, you know, sleep problems, anxiety.
Yeah, so,
in addition to what we were just talking about.
So when you look at neurologically, you know, kind of stepping back, estrogen has more of a stimulatory effect as a neurotransmitter type effect. Progesterone is usually more associated with like a calming effect, GABA supportive effect.
Which is why a lot of times they'll give like a progesterone cream in the second half of the cycle or during the whole cycle.
Or if somebody's
in a lot of cases
peri or postmenopausal and losing the ability to produce, you know, sleep issues, you know, sometimes headaches, night sweats. Again, they'll do things for progesterone. Estrogen, so if it's more of something that can ramp up your NMDA receptors, which are excitatory from a neuro perspective, again, like that's one of the connections on anxiety or kind of overexcitation. So it could be mood. I mean, a lot of times I like to ask and encourage our team to ask, you know, what do you feel like, not when your cycle happens, but as, you know, 4 or 5 days before you actually start your cycle, because that's where we tend to see, at least in, you know, when I go through and do a history, that's where I see the anxiety peaks, OCD might peak. So like the adrenaline / dopaminergic symptoms might peak.
Definitely the sleep problems or nightmares and bad dreams.
And so again, like tying this back to kind of more of like a flow rate of what estrogen and progesterone are doing. And again, if you're going on this decline of estrogen. What are you having to do as a physiological aspect? And there's a reason why we kind of paired this conversation following our last conversation, which was on detox and biotransformation, is kind of as you're meant to be processing these estrogens, is that when you kind of see an uptick in your symptoms? And so, not everybody has genetic tests coming in, but a lot of times,
very few.
But a lot of times you can kind of start to have an idea of what SNPs they may have genetically that might be impacting their physiology. So if you don't know what a SNP is, it's a single nucleotide polymorphism. So let's say I had this recipe, and this recipe was, my wife just made some gluten-free banana bread, so let's go with that. And it calls for 2 eggs, right? But there's a SNP or a single change in this recipe, and I pull out and do 1 eggs. Now, would the outcome of what I'm supposed to create off of that blueprint be different? It may not be as desirable. It may be more desirable. It just depends. So when you look at SNPs, this is how we code and make for different enzymes and proteins. So sometimes it may make an enzyme actually faster. Some may be nothing, no impact at all, or some it may actually slow it down. And so kind of while we're on this conversation, what SNPs or what enzymes and potential SNPs come to mind in terms of female hormones and estrogen?
For sure, catechol-methyltransferase, COMT, is basically what we use in our liver to help with conversion, basically estrogen detoxification, and P450 enzymes for sure in the liver as well. But in the brain, COMT has an additional step or an additional function that is going to play a role in these neurological symptoms.
Right, so because that enzyme also breaks down dopamine and norepinephrine or adrenaline. So if, let's say, it's a little bit on the sluggish side, or you have a SNP that slows down its capture rate or its process rate, and all of a sudden, like, you have this, here's a plate of estrogen, you're already backed up or slow, you may see, and that's kind of how we describe it, it's like it's already not efficient at its job. It's trying its best to handle your dopaminergic needs to clear your norepinephrine clearance, and all of a sudden it's like, here's a bunch of estrogen also in the environment to have to handle. So when you look at kind of detox wise, that gene is kind of also nicknamed the warrior or the worrier gene, as a kind of like a little catchy way of doing it. But sometimes, if you see an increase in dopamine, you might see, really good focus, and you can just be the person that's go, 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 go. But at the same time, if, you may see the anxiety symptoms off of it instead. Another one even downstream that I think is important is looking, not one gene, but all the genes that impact your methylation. So whether it's your MTHFR, your MTR, CBS as well, those things kind of are going to have an impact because, again, it's going to impede how you create something that turns that enzyme on, like SAMe. So I think those have a play.
And when it comes to SNPs, I think the one that people always people think of like genetic testing, it's like MTHFR is probably the one that has the most, is the one that, if you know about anything about SNPs, you've heard of MTHFR, which is an inability to basically use an enzyme that is for B9, like it's essentially for B9, right?
To activate it.
Activating B9, methylated B9, so methylfolate. So if we have issues with that one, but then on the other side of the pathways, especially when it comes to liver detoxification and glutathione production and stuff like that, we also have ones for B12, which I think are significantly less tested.
They're overlooked.
Yeah, overlooked for sure. And oftentimes are as much of in my opinion, as much of a problem as MTHFR problems. Yeah.
Well, and I always kind of, when we do this conversation on the nutrigenomics, MTHFR is kind of at the top of the pyramid in terms of like how much like it will impact things, but a lot of times there are way deeper ones that will make crap hit the fan harder, faster, and much more in your face, especially when you start looking at histamine ones, inflammatory GI ones, like your zonulin type impairing ones. Talked about histamine, GST, your glutathione transferase ones. So some of those SNPs you can be null, where you just actually don't have a functioning glutathione transferase pathway, which those can have a way of also kind of coming in on some of the impact on estrogens. So
glutathione being a huge antioxidant, glutathione being I mean,
especially from a metabolite standpoint in estrogen. If we take, the predominant form of estrogen is estradiol or E2, right? And so the first phase of detox is going to go through a iron dependent or heme dependent, like iron CYP 450 enzyme, right? And so 60 to 80% generally is going to be converted into your 2-hydroxyestrogen metabolite, and that's going to be taken up by that COMT gene. Now, the cofactors are kind of things that support the activity of that COMT gene. It's going to be your magnesium and SAMe are the biggest cofactors that help it do its job. So there's places, just to help out if somebody has anxiety leading up, hey, get them some magnesium, make sure they're methylating, run a homocysteine, can run other methylation panels, look at their methylmalonic acid, see if there's any other deeper issues. But yeah, there's ways to offset it. If you look at another metabolite that's secondary off the phase 1, and again, remember our last week's talk was phase 1 does what? It makes the chemical more reactive, volatile.
Almost makes it more potent.
So again, if you don't capture it and process it, you can see more of a reactive oxidative response, which means it's damaging to different proteins and basically potentially genetic structures. So this is the one that I think is really important and not talked enough, like in terms of the genetic side of things, like the BRCA gene gets tons of attention. But looking at these methylation pathways and then looking at your estrogen metabolites, if somebody has like a family history or just they're having cystic formation, you have to look at a metabolite called 3,4-quinones. And so that's, when you take estradiol and you're going to, I think it's 7 to 11% is going to be 4-hydroxyestrogen. And then the next metabolite, it can pull back into that COMT gene and be methylated, safest route, or it doesn't, and it becomes these 3,4-quinine byproducts, which will basically damage DNA. And that's where you see, if you have an abundance of that, there's associated increased breast cancer risk and estrogen-based cancer risk to it. And it's just, to me, never looked at.
I mean, Dutch Test does a good job of looking at that.
Dutch Test, ZRT, I think, is another company that will look and fraction how you process estrogen, which, again, like it should be like when
people have a family history of these estrogen dominant, female cancers, breast cancer, uterine cancer, ovarian cancers, this should be the first place that's looked at.
Yeah, it's like, how are you processing it? Like, is there any
especially if you've been showing the symptoms of these estrogen detoxification issues for years, like since the beginning, right? But the problem is like the same, like I said earlier, the same treatment is given to the people with these estrogen dominant symptoms, and it's birth control, right? Like
teenage girl goes in, I have an abnormal cycle,
I have heavy flow, or I have
we'll just start flinging different options at you and hoping something works versus stepping back like, okay, why is this happening? Right? Like, is this a bigger picture? Let's, we have coffee in front of us. What does coffee do to some of the detox pathways for estrogen, but just in general?
Just in general, speeds up phase 1, makes things more toxic, but slows down phase 2. And whereas estrogen primarily obviously there needs to be a phase 1, phase 2, but phase 2 detoxification of estrogen, super important.
Right, and stress slows down phase 2, aka some of the stimulant effect.
Environmental factors,
environmental toxins. So we see a ton of mold related issues.
We'll get into some mold stuff in a minute.
But yeah, mold can hit it pretty heavy as well. Candidas, yeast overgrowth,
when you see one of those, oftentimes you see the other too. All these fungal infections and viral infection, viral overloads,
bacterial, like endotoxins. So all these things can dampen down phase 2. And again, just picture phase 2 slows down, so you might see a higher kind of estrogen level over time. Cycle gets heavier. Now you're hitting potentially you're anemic. Phase 1 is now being
because if you have heavier flow, what's happening? You're losing blood. Get your ferritin looked at, get your hemoglobin looked at, get a CBC done. It's like $3.50. There's no reason not to know.
It just makes you want to like bang your head on the table though when you start to kind of go through these cases, and it's just like, okay, so then you kind of see the progression of the snowball. and kind of, oh, you added this and the snowball gained momentum, so you took a synthetic estrogen and it kind of made things worse. So you bounced around 3 or 4 of them and none of them seemed to do well. And they also increased your anxiety. It's like kind of step back and it's really important that your team knows what those things kind of maybe indicate and start pivoting and testing a bit more thoroughly. So we talked about, so test shortcomings. Clearly, often people test randomly throughout the month. Again, if you want to compare apples to apples, and the best time to compare the apple, you always kind of want to be consistent and have a plan. So usually it's going to be post-ovulation, 4 to 6 days, and we got to know when you ovulate. And then too, if there is some trouble in paradise, then we don't want to just run estradiol. Like there's other metabolites way beyond that are going to be incredibly important.
And we said Dutch test. One of the limitations of Dutch testing and basically dried urine testing, and salivary testing and stuff like that, it's not testing your total hormone, it's testing free hormone.
Yep.
Right. So, or it's testing metabolites of hormone.
What you're excreting.
So when you do Dutch, you should probably also be doing
some
blood at the same time, so you can get an idea of what your totals are, not just like here's how much you're metabolizing. It can be a good way of kind of looking at ratios and saying you're kind of a slow metabolizer.
Yeah, exactly. ZRT, we talked, not bad. They'll look at some of the metabolites as well, and
I think one of the big, when it comes to testing, sticking onto the testing shortcomings, not looking at LH and FSH. Like, if you're going to look at estrogen production, you better be looking at the thing that signals for estrogen production.
Yeah, if you don't see a pulse, like let's say it's a female that's played a high collegiate level of soccer for 20 years, has headed the ball over and over again. Like, may there be a neurological impact from what she's done, and would that reflect in a test and impact hormones?
Absolutely.
And so what he was alluding to is, if you don't look at LH and FSH and those pituitary kind of initiating or releasing hormones, you may miss where the problem also may be started, aka kind of up above in the neurological axis.
Yeah, because if they're not ever getting stimulated, you're never going to have production. If you're never told to work hard, you're never going to work hard, right? So it's like one of those things that, and then looking at things that will dampen that on blood work as well. So
inflammation,
first thing, inflammatory cytokines and cortisol, right?
Cortisol,
super easy. Like high levels of cortisol inhibits pituitary output of those hormones.
Certain neurotransmitter modifying medications do as well over time.
Absolutely.
Like somebody's on a ADHD medication, it's very common over time things start to have a downstream effect. Yeah. And so it may look like they have a lower kind of dampened down LH and a low hormone output. And again, we have to look at, is there something in their environment that's suppressing it that is approachable? Is this a consequence of something you just can't undo? Like if it's due to, kind of that pathway from the hypothalamus to the pituitary being damaged and sheared, those are hard ones, right? I mean, this is where
lack of activation and of the hypothalamus to begin with. So like people who are already kind of on the depressed, or it's like chicken or egg at that point. Are we depressed because of low hormone, or are we low hormone because of being depressed or anxious or nervous, or some of these neuropsych aspects of things? Like you can look at those things through examination, but no one's going to, unless you have someone who take the time and say, like, I think some of these neurological aspects are affecting your physiological, or these psychological are affecting your physiological. You're not going to get to the end of it. The end of the goal of treatment should be, how can I get your body working back online the way that it should. It shouldn't be, how can I get you on a medication, or how can I get you on a treatment that you're going to have to do forever because we're just covering up your symptoms.
Yeah, I mean, that's unfortunately way too common.
Way too common. That's why we do this.
If you look at, kind of some of the conversation we had on detox, there's other things, we talked, mold, mycotoxins, inhibiting phase 2, bacterial endotoxins, high stress, high kind of cortisol, high output.
Inflammatory markers.
Markers dampen phase 2. So let's say things make it to the excretion phase, it's in the GI tract. There's other aspects now that have to be at play. So again, it's no, I poop every 2 to 3 days. How's that going to potentially impact?
My wife was just at a holding like a women's conference, a women's retreat, and she just made like a small minor comment about like, make sure you're going to the bathroom every day, and like every woman was like, oh, kind of joking about it, that they only went every 3 or 4 days. I'm just sitting here going like, how much are these problems associated? Like, this is the problem. Like, the normalization, it's common, but it's not normal.
Yeah, it's like, it's normal to be anemic while you're pregnant. It's like, it's more prevalent.
Yeah.
But it's never normal to be.
It's never normal.
Never normal.
To have an abnormal amount of iron in your blood. It's never normal.
To go once every 3 days.
Yeah. It should be food in, food out for the most part, at least once a day.
Yeah, understanding
one
that
solid bowel movement. So getting back to why we need to be having that bowel movement. Sorry about that.
You're good. Kind of went off on a tangent.
Yeah.
But yeah, I mean, let's, whether, and then too, if they have slow transit time, which, from kind of things move slower through to the exit point or the porcelain, again, it allows for greater opportunity for reuptake of these things that you've already processed, right? So you can reabsorb estrogen. Then you can look at, well, what's the bacteria makeup? So there's certain bacteria that can also increase a hormone called beta-glucuronidase that increases your reabsorption rate. So if you come in and you have, bad bacterial makeup in the GI or microbiome, and you have a high beta-glucuronidase, which again, most people won't even look at, but it should be a part of the conversation, you're going to see a higher reabsorption or reuptake of estrogens, kind of compounding them back into circulation. Then let's say you have like leaky gut because you've just been eating like crap. You've had, again, you can get leaky gut after concussion. So again, when did this start? There's many things in the GI just in itself that may be contributory.
Yeah. And so you're telling me you can go through this whole phase 1, phase 2 detoxification. You can do all this great stuff. It goes into the GI tract and you reabsorb it and basically retoxify yourself all over again.
Yeah. Maybe that takes energy. That's ATP.
Yeah.
That's
it's like you did all the work, and then it's at the end of the line, and all you got to do is poop it out. And now we're just reabsorbing it and causing problems again.
And you're not reabsorbing all of it, but you're pulling some back in. It's just like you got a factory line of workers that are kind of already disgruntled, and you're like, guess what? You're not going home tonight.
You take the end product and you deconstruct it. You start it all the way back at the very beginning of that. It's like inefficiency. It just like makes me cringe.
You got to restock the shelves. Here you go. That's basically what you're doing when you have that high reabsorption rate.
Yeah. And that's not just estrogen either.
That's other chemicals.
It's like when like last week when we talked about mycotoxins, and when we talked about environmental issues or biotoxins or all candida, like all this other stuff is happening. I mean, it's unbelievable how often people aren't going to the bathroom, and just by going to the bathroom you can see significant change. And not going to the bathroom as in like, okay, I took a bunch of laxative and I'm just going to do this but I mean, do what you got to do, I guess. Is if you got to go to the bathroom, it's been 2 or 3 days, it's not a bad option.
Right. I mean, stepping back, and it's very easy to see. And again, our neurological, our kind of approach to things always started neurological first. The brain controls everything, right? You have chemoreceptors, stretch receptors. You have all this like feedback that should be happening. Like you put food in, it should cascade this response. You have this peristalsis, this pulse that's moving things to the exit. That's all controlled upstream by the brain, as well as the nervous system in the GI. So again, you look at the person like, yeah, you know what? I can't remember how long I've been constipated, but it probably started right around when I started getting anxious. And then like the cycles kind of hit a wall, and you're like, you start kind of extrapolating like, okay, now we're starting to see, how people can get stuck in these patterns, and it just gets kind of harder, kind of less hope involved. And that's it's such a common thing. It's like the anxiety is going to impact detox, gut function. But then on top of it, you throw some genetic SNPs in, you throw some estrogen clearance issues, and you just start seeing this cycle where you're like, no wonder you're frustrated. But
and all those things start fairly early on. It's like it can be, first time that we're having, not we, but it's first time a female's having a cycle, and it's like you start this process early. right? And the crazy thing is like the time women start having, or young females start having cycles, is getting lower and lower and lower, right? It's kind of scary.
Yeah,
like,
and I think there's also research too that if you have some of those polymorphisms, you're also more likely to go through puberty at an early age. So again, it's like, hey, if you went through like 11, but your friends went through it at 13, you're having anxiety, like those may be things like, hey, should we step back and kind of have some insight into these things?
Yeah, it's crazy to see. I mean, I think I saw, government agencies saying like it's normal now to start at 9, 10, 11 years old. And it's like, ask any woman in their 50s and, hey, when did your friend group start? It's like 14, 15, 13, kind of in that range. And it's like we're seeing younger and younger and younger. I mean, there's a lot of theories out there why it's happening. Environmental.
Chemical. We're getting hit.
Yeah.
Plastics. Even your BPA-free alternatives. BPA-free alternative plastics. They're no better.
Yep.
So I think this has been a pretty thorough discussion of female hormones. Relative to this last weekend, we were up in Michigan. Likely a good mold case with why this lady was having some dysautonomia.
They were going through this, and it was like specifically dysautonomia, and focused on the neurological implications and the neurological causation. And 2 minutes into it, Dr. Rayner and I just looked at each other like, this sounds mold.
Yeah. She histamine responses that wouldn't break away from the skin 30 minutes after doing a pinwheel test or having
the VNG
goggles on. But so kind of pulling in mold, and obviously it can have neurological consequences, but tying it back into just the hormone consequence. One, you can have impact to the hypothalamus from the inflammatory cytokine response, which again dampens that access from the hypothalamus to the pituitary. But what about certain types of mycotoxins directly?
So one of the mycotoxin, and I had a patient with this yesterday that I was kind of going through, and we were doing a Zoom call. She was in California, so I was doing a Zoom call with her, and I shared my screen because I was showing her basically this research study talking about zearalenone and how its effect is estrogenic, right? So it's like it mimics estrogen. So even though her estrogen levels on her tests are always fairly normal, it's as if there's a stimulant into the receptor that isn't being picked up by blood work. And guess what? She's like, oh, do you think that has to do with my really bad cycles and my really swollen fibrocystic breast issues, and basically cup size went up significantly, getting weighted around the midsection and into the legs, and there's all these different estrogenic effects that mold specifically can have on female physiology.
Yeah, especially if it's certain mycotoxins, right?
And she was just told uterine fibroids, polycystic ovarian syndrome, and it's like, maybe we're just blasting these estrogen receptors. And the interesting thing is, she shared, she lived in an apartment, and the girl next door was basically suing the apartment complex because of this mold toxicity in her apartment, and she got the test results from the neighbor. And the number one thing, they were all high. Trichothiazine, aflatoxin was normal. Trichothiazine group was high. Ochratoxin. Glio was high. But the highest was zearalenone. So it's like you got this estrogen mimicker. So even though your physiology might be working perfectly fine, you have this thing being thrown in there that isn't picked up on lab work that's showing essentially all these high estrogenic effects. So symptomatically, she's showing these high estrogen issues. Blood work is saying, no, your estrogen's fine.
Yeah, and then that's not, when do they actually test it? That's the other aspect, right?
Yeah, that's the thing. It just, usually it takes years and years before they find someone to do estrogen tests or mold testing. So we sent her a kit yesterday to get some estrogen, to get some mycotoxicity. Yeah,
it's just crazy. It's just overly common and unfortunate.
Yeah, but like we talked about with the detoxification effects, what is that zearalenone having on the liver? What are the estrogen detoxification effects of that? It's is phase 1, phase 2 working appropriately when you have that mycotoxicity? What are those cytokine activations doing to the hypothalamus? And
it can come at you in many ways, right? I mean, so environmentally, chemically, food you put in, like become insulin resistant, start to get metabolic syndrome. That's going to screw up hormones and their ratios for sure.
Yep.
And so all these things have such an impact. And you know, again, so like I would say, are you having a fasting insulin run? And are you comparing that with your fasting glucose? Are you generating a HOMA-IR score, an estimate of your insulin resistance, right? I mean, if those aren't being run yet and you're having problems in this department, like it's time to start asking these questions. So we're trying to just kind of empower kind of with different lab markers or different kind of questions to be, poking around at your provider and just trying to get a better response. I mean, a lot of times, people
at least start having the conversation, right? Instead of it just being swept under the rug. Like, same patient, she's like, my alkaline phosphatase is always super low. My MCV is always super high. And I'm like, MCV? Like,
there's B12.
Yeah, there's a B12 problem. And it's clinically high. And no one's ever said, hey, by the way, maybe you should.
So that's a megaloblastic anemia. So not only an oxygen delivery problem potentially to small capillaries, but on top of it, like another sign, like does that have methylation impacts?
And that's exactly what we were kind of talking about. So, I mean, it is, there's so many things. It's not just as simple as like, is your estrogen good? And are we going to do a replacement, right? Are we going to do a pellet? Are we going to do a cream? Are we going to do, it's like, there's so much more that should be looked at when we're talking about these female hormones, because, your body wants to work the way that it should work. There's nothing that should be holding it back. The idea is finding where those little maybe bottlenecks, or maybe where the floodgates are open, or if there's something mimicking, or if there's some kind of environmental, nutritional
history, like were there things environmentally or kind of trauma, like were there things that kind of came in and like had enough of impact or kind of partnered with other impacts to start to create kind of disruption? I think that's it.
Exactly.
So, well, I think, is there any other, I'm trying to think, any other notes we kind of really want to make sure we dived into or kind of at least touched on? I mean, we could always come back and do more into this.
If you found this helpful, or if you have other questions, send it to us and maybe we'll do a podcast on it.
Yeah, we can
podcast about the question.
Yeah, we can definitely do more. Again, this is not meant to be, this is purely informational.
No diagnosis here, but if you're hearing something that sounds familiar, like seek help.
Yeah, informational, no medical treatment is being rendered here. So again, if you do have questions, please reach out to our medical providers or your medical provider. Again, this is purely for informational purposes. So, well, excited to catch up on the next one, and I hope everybody has a great day.